welcome back to another episode. And before we start, I do want to thank my lovely co-host today for refilming with me, as the audio from the last episode, unfortunately, wasn't usable. So today we're hopping on Zoom for an emergency podcast episode. And today we're going to be talking all about acute myeloid leukemia, which is a group of blood cancers characterized by rapid proliferation of immature myeloid cells in the bone marrow, which result in dysfunctional hematopoiesis. There are many types of AML, and each type has a different genetic mutation that affects how it will progress and determine which treatment is the best option. There are three main types of treatments available, such as chemotherapy, allogenic stem cell transplants, and targeted immune therapy drugs, which we'll touch on a little bit later. I also did want to mention some of the prognosis and prognosis factors. Advances in treatment of AML have improved complete remission rates over the years. 60 to 70% of adults are expected to achieve complete remission after appropriate treatment. And more than 25% of adults with AML can be expected to survive more than 3 years. And of course, age at diagnosis does affect your prognosis, with more than 65% of those younger than 60 years old achieving complete remission rates.
Thank you, Jimena. So now we're going to talk about how does this cancer develop. And so patients with secondary acute leukemia most commonly develop AML. So what is secondary leukemia? It is a leukemia that has been developing in patients who have a history of exposure to therapeutic agents and stem cell disorders. The positive correlation is seen also with rheumatoid arthritis and myeloid leukemia. And the reason is because if you have rheumatoid arthritis, you are taking anti-rheumatic drugs, which is called DMARDs, and they are anti-TNF agents. And we all know that TNF alpha is one of the most important regulators of the inflammatory process. And autoimmune diseases and other diseases and their link to this cancer development of AML remains very unclear and still being studied. But also we have seen that myeloid neoplasms are clonal hematopoietic malignancies in the body, and this causes clonal expansion that is happening in the blood, and this impairs differentiation of red blood cells. And this, of course, can lead to AML, and it's one of the most promising links to AML. Now we're going to skip to a video that's been circulating throughout the medical community by Dr. Landazuri, and this is it.
So we just finished discussing what the NK cells and CTLs do when they encounter the cancer cell and how they become activated to release cytotoxic activity. Some examples of cytotoxic activity that NK cells can perform are the release of perforin and granzyme, or antibody-dependent cellular cytotoxic activity, which occurs via CD16 engagement. In regards to CTLs, they can induce apoptosis, which is mediated by the FAS ligand. However, whichever route of cytotoxicity that NK cells or CTLs perform, it leads to the same outcome, and that is the secretion of interferon gamma and chemokines. And these two are the key players in getting signaling to the rest of our immune system. So what essentially interferon gamma and chemokines do, it stimulates adaptive immune cells. It does that by increasing the perceptibility of tumors through the upregulation of MHC complexes, whether that be class 1 or class 2. It also promotes proliferation and activation of TC and Th1 cells that are going to later secrete even more interferon gamma and chemokines. So we can kind of see that positive feedback loop happening in the adaptive immune cells. This initial secretion also stimulates innate immune cells as well. And it stimulates them by enhancing effector mechanisms and facilitating tumor recognitions. And it also enhances interferon gamma secretion in innate immune cells. So again, we see that positive feedback loop again in the innate immune cells. Lastly, this initial secretion stimulates immune suppression of tumor cells, and it does this through upregulation of checkpoint inhibitors, such as cell death ligand 1, and upregulation of endoleamine 2,3 dioxygenase, which plays an important role in the peripheral tolerance of tumor antigens. So with the stimulation of our adaptive and innate immune cells and the immune suppression of our tumor cells, we get this link between the innate and immune cells that allow us to have a sustainable and effective immune response towards the tumor cells.
Thank you so much, Dr. Landazuri, for sharing that video for all of us in the medical community to see. I did want to also talk about what other immune cells become involved and what they do. First, the cells of the immune system detect AML through T cell receptors and natural killer cell receptors. As Bree had mentioned earlier, natural killer cells detect changes in MHC class 1 levels on the cell, and if the expression of the protein has significantly changed, these cells will mount their immune response through degranulation. CD8 positive T cell receptors recognize the cancer through 3 types of protein expression on MHC class 1. These consist of altered self-peptide presentation, an embryonic protein presentation, or significant overexpression of self-peptides. Research on AML has shown that expression of embryonic proteins through the translation of OCT4, NanoOG, SOX2, and SSEA3 genes. These genes all encode for transcription factors that aid in stem cell differentiation, with the exception of SSEA3, that's a glycolipid protein used for cell identification and cell signaling. After these cells have been detected as cancerous, cytotoxic lymphocytes such as CTLs, natural killer cells, natural killer T cells will work to destroy the cell through degranulation, and CD4 positive lymphocytes that express the T-BET transcription factor will recruit lymphocytes through the production of cytokines. Natural killer T cells also induce phagocytosis for phagocytes by producing IL-12 for dendritic cells.
Now that we know about the molecular level, thanks to Morgan, we're now going to talk about what symptoms you can see with this cancer. So first, immune tolerant mechanisms are placed in our body, are normally there to protect our healthy tissues from autoimmune disease, but it can also create a barrier to attack tumor cells. Proper T cell responses against self-proteins is very challenging as T cells undergo negative selection after being in the thymus. And negative selection is when a T cell is made sure that it can attack our own proteins, our own cells. AML is a systemic disease that can compromise the whole body. Common symptoms of AML are fatigue, constant infections, bruising easily, and fever. And there's a 5-year overall survival rate of 28%.
Thank you so much, Julia, for sharing that with us. I also want to talk about how this cancer gets cleared and resolved. Some cases have shown spontaneous clearance of this cancer, and this is possibly due to the cells I described earlier. However, mechanisms of clearance are mainly subject to medicines and therapies. Most predominantly used is chemotherapy, which is not a good long-term treatment for AML, as blood cancers such as AML have shown to become resistant to chemotherapy over the courses of relapses, which blood cancers are very prone to. However, a paper published in Blood has shown new treatments using CARs T-cell therapy, which has been shown effective against AML in an in vivo model. Currently, there are more clinical trials going on using CARs T-cell therapy, one of which, as at Stanford with Dr. McCall, is using this treatment on solid tumors using the B7H3 antigen. The FDA has also approved CARs T-cell therapy against 5 types of cancers using antigens CD19 and BCMA. These cancers are B-cell acute lymphocytic blast leukemia, B-cell non-Hodgkin's lymphoma, follicular lymphoma, mantle cell lymphoma, and multiple myeloma. The effect the immune response has on this cancer includes but is not limited to the cells and mechanisms we described. They can aid in the clearance of the cancer through mechanisms of both the innate and adaptive immune responses that include but are not limited to phagocytosis, degranulation, and activation of the complement cascade. These mechanisms can lead to cell lysis and induce apoptosis from cytotoxins.
Thank you so much, Morgan. So one of our final segments is the open-ended question segment. And this week's question is, drumroll please, will the use of T cells expressing chimeric antigen receptors that specifically direct T cells towards cell surface tumor-associated antigens be a more potent alternative therapy? We hypothesize that CARs may be a promising avenue in the targeted therapy of acute myeloid leukemia, as other research has developed CARs with targeting ability in B-cell malignancies. and have actually gone on to phase 1 clinical trials. And the use of flow cytometry analysis was key in identifying if primary acute myeloid leukemia cells are specifically targeted by CD123 specific T cells. In the context of CAR T cells, flow cytometry can be employed to assess their specificity and also to assess their targeting capabilities. And they do this in a few steps, but I'll quickly summarize it. The sample is introduced into a flow cytometer machine, which analyzes individual cells based on their physical and chemical properties. The cells individually pass through a laser beam, and detectors measure the scattered light and emitted fluorescence.
To wrap up our discussion on AML, I'm going to talk about its impact, who can benefit from this knowledge, and who is studying and funding this work. So the people that are most infected by AML are adults, and it's very uncommon before the age of 45. It's a very rare form of the disease and only compromises 1% of all cancers. The impact of this disease economically can be seen through relapse episodes, which can cost anywhere between $400,000 and $500,000. Hematopoietic stem cell transplantation is about $300,000, and high-intensity chemotherapy is about $200,000. This is an average of all the costs, but it is very costly since all of the treatments are usually done with chemotherapy, transplantation of cells. And one of the biggest global impacts is that the research that is being done by AML is funded by LLS, which is the Leukemia and Lymphoma Society, and 1/4 of its research dollars goes to AML. And there's approximately $142 million going into this. But we would recommend a routine check of your blood once you're over the age of 45. And if you have any autoimmune disease, or if you have rheumatoid arthritis, or if it runs in your family, it's very encouraged to get a routine blood check. And it is very inconclusive right now, all of the treatments of AML, since it's very hard to treat because it's our self-proteins and a systemic disease that compromises the whole body. But thank you so much for listening about our talk about AML, and thank you for Dr. Landry-Zuri for bringing awareness. And don't forget to tune in next week. Thank you. Bye.